Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon, everybody. Welcome to ASAHI series, PCI Know Your Tools webinar. Thank you for joining. This virtual course is designed for interventional cardiology fellow or interventional cardiologists who want to learn about the fundamental of PCI hardware and its practical use. If you stay with us on the coming 2 hours, you will get a deep dive into PCI device and clinical technique from a lecture and interesting case example from the PCI expert in this field. And today we also have the product specialist from ASAHI Intech. So if you have a question about the device, both clinical use and the technical question about the device, you can ask by drop your question in the chat box. And after the lecture or the case presentation, we will have some short question. I will select some question to ask the presenter after their lecture. And after that, at 3:45, we will ask all the questions again if we have enough time. So first, we will start with the topic of the guide wire. So the topic is about the fundamental of the guide wire, presented by my longtime friend and mentor, Dr. Wataru Nakamatsu. Dr. Wataru Nakamatsu is the director of interventional cardiology from Hokusetsu General Hospital, Osaka, Japan. He is the very expert in this field. So he knows very well about the guide wire, especially a CTO wire. So please, Dr. Nakamatsu.
Thank you very much, and good afternoon, everyone. Thank you very much. A very nice introduce. Okay, and let's start this my lecture. Okay, anyway, first of all, thank you again, and I deeply appreciate inviting me. And thank you very much for the ASAHI company for the supporting this meeting. And can you see that? Not yet?
Yes, you can see.
Okay. Can you see my slide?
Yes.
Yes.
You can see the PowerPoint.
Please do the slideshow. Yes.
Okay. Just a moment. Okay. Okay, and let's start my lecture. My lecture title is Fundamentals Guide Wire. As you know, so usually I lecture about the focus on the CTO PCI, but in this time I would like to switch move to on the fundamental guide wire, especially shown one. And I would like to show the case. This is RCA and the RCA region. And from the middle part, we can see the severe stenosis. And very unfortunately, we can see the very tortuosity and the middle part and the proximal part too. It looks like very difficult to insert the guide wires. So this is a aerial view, and still we can see the tortuosity and a very severe tight stenosis, and especially the proximal part. These are situations very difficult to get advanced guide wire. But in this time, then I choose a Sion guide wire. Because of this Sion guide wire have the good maneuverability and good durability. And actually, as you can see, this movie and show this guide wire movement. And even if the excess this very big bend, but still this Sion guide wire can keep the control. And after that, and especially this part looks like a corkscrew part, and usually they're very difficult to the passage. And this part, and even and format type guide wire. Usually in this time we have to choose the polymer jacket guide wire. But as you know, this polymer jacket guide wire have um, the risk of the perforation, and sometimes automatically get advanced to the small branches and more distal part. And in this time, we would like to choose the steel coil wire. And but this Sion guide wire, you know, the Sion guide wire is a coil wire, and keeping the in the vessel and keeping the good handling, good maneuverability, like that. And amazingly, and excess the very big bend, and still this guide wire, this Sion guide wire keeping a good maneuverability, like that. And finally, we can get good result like this. Why the Sion wire have the good control? And because of the this guide wire have the composite core. And please look at this movie. And this one is a normal core guide wire. Normal core guide wire has a very simple structure. But on the other hand, this Sion guide wire have a little bit complex, and we call the composite core. And one of the cable tubes, and another one is additional coil and springs, and finally the whole and the outer coil. So we call that this ASAHI Guide Wire new technology is a composite core. I would like to explain more and using this picture. And please focus on the proximal part of this Sion guide wire, this part. And from this proximal part, including the not only the normal outer coil, and the inner side, this guide wire have the cable tube like that, cable tube. We called another say Act 1 system by the Asahi. Looks like a double coil, like that. And move to the focus on the distal part like this. And the distal part and included not only the core wire, and additionally the twist wire have the this distal part. It looks like a double core. And basically, as you know, the round core is have the good maneuverability, good transmission efficacy, but additionally, this twist wire have the good efficacy. And this is one of the key slides of this lecture, made of the composite core. And the portion part and this guide wire have their cable tube, another say Act 1. And this Act 1 cable tube benefits is one is a good torque transmission, and another one is a good durability. And move to the distal part. Distal part and have the round core and twist wire. And what is the benefits and for the having those two core system? One is a good torque transmission and flexibility, and another one is a good durability. And so we would like to check the in vitro and in vitro experience. And I will show the prevention of wave motion. How about that? Left side is there. This is a guiding, and this Sion guide wire already inserted via this guiding, and the rotation by hand. We can see the very smooth moving like that. We cannot see the wave motion, and after using a Sion guide wire. But on the other hand, and format type guide wire, we can see the wave motion. and looks like in this time looks like a very slowly but suddenly quickly moving this guide wire. We call this movement is a wave phenomenon. And I show that this graph. So this one is in vitro test and estimate the torque and the wave test. And this vertical line is the output angle and the horizontal line is the input angle. And as you know, an ideal line is a 45-degree, one-to-one torque, like this black line. And please look at this yellow line. The yellow line is a former type guide wire. A former type guide wire looks like and potentially and the transmission power and the torque movement is transmitted to the distal part. But we look at this straight line. So in this time and suddenly released this torque power, and there in this time and easy to occur wave motion like that. But on the other hand, this Sion guide wire is this purple line is very close to the ideal line. So this in vitro test show that this Sion guide wire have the very nice torque transmission. And I show this Sion durability. So this based in vitro model pushing this Sion guide wire, but after that keeping this shape. I showed another one. So this one is a crash test, in vitro crash test, and for the estimated durability. And the left side is a former type 1, and the right side a Sion guide wire. And pushing this guide wire like that, and in a diameter 2.65. And after that, and remove this guide wire and already crushed this guide wire after that pushing this guide wire in the Homer type. But on the other hand, the Sion type is keeping the pre-shape like that. And as you know, the Sion family is 3 types guide wire. One is a Sion, and the second one is Sion blue, and the last one is a Sion black. And all Sion wire family and have their composite core. And due to composite core, Sion family have the good control and the good durability. And I show the Sion structure. And yes, and so and as you know, Sion guide wire have the composite core, and another and another point is full coating, full hydro coating like that, and the tip load is 0.7 gram force. And the Sion blue structure is a little bit different compared with the Sion one. And composite core have 2, but this Sion blue and guide wire don't have full coating, and expect tip 15 millimeter. And from the tip, 15 millimeter don't have the hydrophilic cord, more safer wire compared with the Sion one. And their tip load is a 0.5 gram force, a little bit lightweight compared with the Sion one. And how about the differences between Sion and Sion blue? And lubricity analysis slipping is of the Sion blue is slightly less than Sion. And maybe they have the efficacy and for the safer. And the support performance of the Sion blue is slightly better than Sion. And because of this and the double coil part is a little bit extended to the tip cord, and due to core management. And last one is a Sion black structure. And yes, and Sion black and have the composite core too. And the another specification is a polymer jacket. And this Sion black have the full polymer jacket, a very nice lubricity, very sleepy guide wire compared with the Sion blue and the Sion. And hydrophilic coating, full coating, and the tip load is a little bit heavier than the Sion and the Sion blue, 0.8 gram force. What is a Sion black? Please image this one, and the composite core plus polymer jacket, A core, and Sion black. A lubricity of Sion black is better than Sion. This slide is one of the key slide for this lecture, and ASAHI SION Family positioning. Please look at this figure. And this vertical line is a guide wire stiffness and lubricity, and the horizontal line is a more light wire, is a more complex region. And Sion blue, so this blue area is a regular case. This pink color area is a complex case, and this purple area here is a CTO case. And Sion blue is supported the basically the regular case. Sion blue is a safeness, have the safeness and the supportability. And I would like to recommend for the normal case. And actually, in my hospital, and Sion blue is used as the first and the guide wire for the normal case. And Sion is supported the regular case and the between the complex case. Sion is a very balanced with safeness and crossability. And the please choice for the regular to complex case. And the last one is Sion black. Sion black is a good crossability. The first choice for the difficult case, like a torture part and the classification and the strong bars and the beer stem strut. I would like to recommend. And I show the Sion blue case. This is RCA region. We can see the significant region in the distal part of this RCA. So in this time, even if the passes the guide wire, and additionally, and get advanced, there are another devices. In this time, very easy way to the automatic movement and move this guide wire. So in this time, so we worry about the guide wire perforation. And so in this time, so I choose a Sion blue guide wire for the safe. And they're including the main torture part, we need a support power. And that's why the second region and for the choosing the Sion blue guide wire for this case. And actually the passage the Sion blue guide wire, and so the after that, and a very easy way to the choose the good branches like that. And finally, we can get good result like this. And I will show the Sion black case. So usually we use the Sion black and for the classification and the tortures and the insertion the via stem strut. But so this is a very impressive case for me. So this case is RCA. And so actually this patient suffered from the AMI 5 days ago and coming to our hospital. And we can see the very big bend production part of this RCA. And there's I already information in the informed this case. And maybe the 5 days and after maybe this thrombus a little bit harder than the normal AMI case I worry about. And firstly, I choose a Sion blue guide wire and Sion blue guide wire and for the safe. But very unfortunately, in this time, very difficult passage, this thrombus part, maybe this thrombus a little bit included hard matter, and extend to the wire Sion black for the getting more lubricity. And after that, extend the guide wire from the Sion blue to the Sion black, and a very easy way to get advanced more distal part like this. Is maybe the Sion black, the lubricity have the good efficacy for the passage of this hard thrombus. And finally, we can get good result like this. And move to the more complex cases and for the using the Sion families. And so this is their CTO data from the Japanese CTO PCI Expert Registry 2016. And I already published this data via Euro intervention and in this year. And I show the prevalence of guide wire types in the collateral channel guide wire crossing success group. And please focus on the this septal collateral channel groups. And as you know, nowadays, mainly we choose the SO03 guide wire for the passage, the collateral channel. But still, this Sion guide wire have the good efficacy. Please look at this. And for the septal collateral channel, and SO03 is a 41%, and the Sion guide wire is still have the big range, 38%. And I showed the actual case. This is as a CTO, and I tried to retrograde PCI using this Septal channel. This Septal channel is connected to the RC Distal part. This is a tip injection and using the Corsair. And we can see is a connection. But unfortunately, distal part of this Septal channel is very uncertain. Looks like a thread-like connection. And from the J channel score, and maybe this channel have the score number is a 2. 2 is an intermediate. And from the Japanese CTO PCI expert registry, and if this channel is an intermediate, and from the Japanese CTO PCI expert registry, the success rate is 50%. 50% means this channel is an interventional quarter channel. And so in this time, I choose the Sion guide wire as a first guide wire for the negotiate this channel. And I would like to inform you and tips how to use this Sion guide wire for the torches and septal negotiation. And please make a bend and almost 19 degree. And there are very easy way to the passage, a very tiny and severe bend. They are like that. Base Sion guide wire is very have a good efficacy for the jails like the channel. So I suppose, and how about difference the compare with the pseudo guide wire? I think a little bit more good supportable and more good pushing power and have compared with the pseudo guide wire. And so another suggestion how to use a Sion family for the complex case. And I'll show the knuckle technique. Usually I choose a Sion black guide wire for the knuckle technique. This CTO is an instant CTO. And from the beginning in the stand and the distal part in the stand like that. And so in this time I use Corsair and Sion black. And Sion black is a brand pushing, and after that automatically change the knuckle shape like this. And get advanced to the CT region. And I check the guide wire position and angiography with that contrast looks like, and looks like be in vessel from this rotational angiogram. And finally, we can get good result like this. Take home message. Sion guide wire family have the composite core, and this composite core realize good handling and good durability. And Sion have the full hydrophilic coating and a good balance have. And the Sion blue have the partial hydrophilic coating, so they have the safeness. And I would like to recommend using a Sion blue for the fast guide wire for the regular case. And Sion black is a polymer jacket and have the good lubricity. And this is a last slide. And I would like to inform again, and ASAHI SION family positioning like that. Sion blue is for the normal case, and Sion is a regular Sion is have the well balance with safeness and crossability. And the Sion black is a very nice crossability like that. Thank you for your attention. Excuse me, and Dr. Mimpe, and you on the mute, yes.
Oh, sorry.
Yeah.
Thank you very much for
Welcome.
the very informative lecture. So I have a quick question for you. So which guide wire do you think is most suitable for stem cell recrossing to the side branch?
Okay, good question. Yeah, and I usually Sion guide wire, and because of the have the good balance and good balance, the lubricity and support power. And if using a Sion blue guide wire, I worry about sometimes very difficult to remove. remove, and due to their from the tip 15 millimeter don't have the hydraulic cord, and in the Sion blue guide wire. So I usually use the Sion guide wire.
And for the side branch,
Yes.
recrossing. I mean,
Yes, side branch and the recrossing too. Both.
Yes.
Both.
was
Yeah.
Sion.
Yes, Sion.
And,
if the and so if the fail the okay, and okay, when I choose a Sion black for the side branch, yes, very heavy calcification region, and even if the Sion have their full hydraulic cord, it's sometimes very difficult to remove. And for the very calcified region, and I would like to use a Sion black guide wire.
So, what do you think about the safety of the hydrophilic or polymer jacket guide wire used for the gel wire for the side branch of protection? Because in the past, we were taught that we should not use the hydrophilic wire for the gel wire. But recent study show that the wire fracture and the polymer sharing occur more frequently in the non-hydrophilic guide wire. So what do you think about this?
Okay, very good question. Very difficult to that, but I would like to using the just only have the full hydraulic cord, and so I usually I worry about the guide wire perforation at the side branch, and sometimes very easy way to get advanced to the more distal part using the polymer jacket guide wire. And before, when I started PCI, I usually the polymer jacket guide wire for the side branch and the guide wire jelly. But so I watched so many cases, and not my case, and very easy way to the power rated. And so yeah, and I would like to use the Sion guide wire. Just only have the high hydraulic cord.
May have the opinion from Dr. Viraj on this question as well.
Yeah. For me, I still wonder about the hydrophilic guide wire, especially that the polymer jacket coat in the sidebar protection in the first practice of my intervention. Since there are some example of the hydrophilic polymer jacket coating guide wire in the puncture situation, which you use with the needle that have a very sharp edge. But in a stent, we know well that the stent surface have been polished very well, and there is almost very safe to cross the fragile artery. So for the artery wall, they not be harmful. So why the polymer jacket coat, why be harmful? So when we know this factor well, we use the polymer jacket coat wire for the sidebar protection with very comfortability and very happy to use it. And very rarely to have the guide wire entrapped in the this side branch, except for some situation, especially in the calcified region. Yeah.
Okay, thank you very much. So thank you very much, Nakamatsu Sensei.
Thank you very much. Thank you very much.
So, but please stay with us.
Yeah, yeah, sure.
So we will move to the next session. Is a case presentation about the usage and the selection of the guide wire, presented by my friend Dr. Thanawat Srisat. He is the very active interventionist in the northeastern part of Thailand. Dr. Thanawat Srisat is from Khon Kaen Hospital. Please, Dr. Thanawat.
thanks Dr. Nguyen for my introductions. Good afternoon, everybody. Our panelists, Dr. Nakamatsu, สวัสดีครับ อาจารย์อเนก อาจารย์วิรัต อาจารย์เหมือนเพชร and everybody here. I would like to thank ASAHI Intex company for inviting me to coming here today. For sample case one is a not difficult case, but it's a real life common practice in the urban hospital. My case was Thai male, 60-year-old, presented with chest pain one day before admission, but however, he has the chest pain off and on around 4 to 5 months, no PNG orthopnea. He has a history of diabetes, hypertension with optimal medical treatment. Physical examinations show high blood pressure and no sign of heart failure. Did the chest ratio micardiomegaly without primary congestions. EKG show normal sonar rhythms, left ventricular hypertrophy, poor progression without significant STG change. But however, the cardiac troponin was rising with normal kidney function. This is the echocardiogram. At the first time, show hyperkinesia as the anterior wall and very severe or akinesia at the apical portions, every ejection fraction around 40%. And you can see the apical AV thrombus here with minimal mitral regurgitation from the echo. So patients was sent to the cath lab from acute coronary syndrome. This is the left coronary system show occlusion at the proximal at the mid LAD lesions and maybe sometimes subtotal occlusions. You can see the like the macro channel. Yeah, the distal part of the LAD look the diffuse lesions or maybe from the severe stenosis at the proximal part. Circumflex is dominant and minimal disease. And ASAHI have two small vessels with minimal disease too. Patients were diagnosed as a non-ST elevation MI with ischemic cardiomyopathy with single vessel disease. From echo data, we concerned about the viable or non-viable myocardial. So at that time, patient was treated with medical treatment only and start warfarin from LV thrombus. Patient was sent for viability test to confirm viable myocardial and still viable myocardial for anterior portions, except the very little part at the apical portions, that small area. Patients still to have the chest pain off and on after that, so state PCI was performed 3 months later. We repeat the angiograms at the left side system. You see the blunt stump at the mid LAD at the septal branch. The macro channel looks disappear. Otherwise, it looks like the same previous angiogram. This is the previous angiogram at the CTO lesion. So you have the many guide wire in your cath lab in the market. So which wire or which one will you choose? Basically, we classifications the CTO crossing guide wire in 3 groups of the guide wire: that soft guide wire, that the tip load less than gram force, intermediate guide wire tip load between 1 to 4 gram force, and stable guide wire is more than 4 gram force. Basically, which one that you choose the first wire? We will start from the softer guide wire and depend on the anatomy of the CTO. If you see the macro channel clearly, you maybe start with the XTR. Or the stump looks stable, you maybe start with XTA. If your stump is look blunt stump or without stump, you maybe start with XTA or the guide series, that's the guide first. And you can increase stiffer wires. We call the wire escalation to more stiffer when you miss the hard plug or calcification from the feeling from your fingertip. That is the common practice. From Asia Pacific CTO algorithm, recommendations for the wire escalation from the Antegrade wire based strategy, and depend on the anatomy, as I said. But however, in my case, I start with filter XT, original XT, because I don't have the XTR or XTA in my lab at the time. With conventional filter XT have the polymer jacket wire with the stopper tip load, 0 pi S gum float, and table tip to 4-track micro channel with the sliding concept or reeling concept, and support with micro catheter and Geisler motor and shine. With the stopper tip load, I cannot puncture the proximal cap with the filter XT, and I step up with another polymer jacket wire, the Pilot series from Abbott company. I start with Pilot 50 with the 1.5 gram force, but fail, and then step up to the Pilot 200 with the 4 gram force that the intermediate wide. However, it failed again. When I try to puncture the proximal cap, in usually anatomy of the proximal cap have the thick and hard and usually convex with the calciums. If the guide wire you cannot puncture, guide wire usually slip to the septal band with the less resistant area. In this situation, in some case, I maybe use the double lumen micro catheter for increase the penetration force, or maybe sometimes use the ETOSS guide to find the proximal cap for the puncture. But in this case, I use the ACVA to step up to the stiffer wide. This is the Pilot 200. You can see the slip to the septal band. And it is the collateral from the RCA is the minimal collateral is not suitable for change to the retrograde approach. So when I use the polymer jacket wire with solver chip FUDXT Pilot 50 Pilot 200, that is the sliding, it is the drilling out sliding technique. It is a passive wire control, not the active. When the wire meets the with the hard resistance or hard plug, the wire will go to the lesser resistance. So the next step, I decide to the stiffer wire. I choose the Conquest Pro. Conquest Pro is the penetration techniques that have the higher, stiffer 9 gram force with the taper tip as the filter XT and hydrophilic coating. However, I pre-shape the tip of the guide wire to more steep angle. It looks like when you try to the repuncture from the subintimal space through NT to the true lumen to far away from the septal branch. With the higher stiffer wires, I can puncture the proximal cap of the CTO body, but however, I could not redirect or advance the wire go to the distal cap. I feel like that something have a very high resistance before the go to the distal cap, and the Conquest Pro go away or go outside the vessel lines. I try to form many times. So this is the stepwise. This is the penetrations concept. If you could not penetrations, the calcium or the hard plug and the wire will go away from this resistance and maybe go outside the vessel. This is the penetration concept from this group of the guide wire. For the key factor of the CTO guide wires, when you go to the different stiffness of the layer of the vessel, you feel the resistance from your fingertip. So at this point, you choose the rotation the guide wire to the other relations, and then advancement. But it's cannot done with the Conquest Pro. So I change to the guide wire is the guide wire from the ASAHI company. The structure have the composite core that have the more flexibility, and the tip is the microcone shaft tip. The guide have the tip load around 4.5 gram force. With this type of the guide wire, you can do the active wire control by deflection and directions control that we call the active wire control. go to the distal true lumen. This is the diagram when I use the concrete ball, and I feel like I missed the calcium before the distal cap, and I could not puncture this point. The guide wire far away and go out the vessel. And when I change the gyre series gyre, I can move from the calcium and can really go to the true lumen. This is more flexibility. This is the guide wire. Finally, I think I can go to the distal to lumen with the guide wire. And need to recheck with another direction, orthogonal direction. It's very important when you use the single planes X-ray machine with the CTO PCI. You need to do the orthogonal view or multi-view for check your guide wire position. Even the guide wire have the low tip load, less than concrete ball, but it had the high penetration force more than concrete ball. Why that? Because penetration force is a tip load and divided by area of tip. If you have the same tip load guide wire, but another wire, you have the smaller shape, tip shape. So this guide wire have the more penetration force. When I compare the concrete ball for penetration force and guide wire, you see that the guide wire have the higher penetration force more than the concrete ball, because it has a micro cone chip. It is the smaller chip area. Besides that, guide wires have the more tip flexibility more than the concrete ball. This is the model from the ETOSS, from the side-band occlusion CTO. You can see that guide wires and concrete ball could not puncture the proximal cap to the side-band occlusion, but guide second cannot done for this. And after go to the CTO vessel, you can see the guide wires have the more controllable with the tip shape flexibility more than the concrete ball. After the wire go to the distal cap, the CTO was related with the 1.25 balloon and 2 balloon. And then we check the IWAS. Luckily, the wire passed all the 2 lumens from the proximal cap to the distal cap of the CTO body. You can see this is the part that the calcium before go to the distal cap. Okay. I think the concrete ball missed this point of the calcium, and it make the concrete ball could not penetration at the calcium in this point, and it make concrete ball to go away outside the vessel. But guide wires can redirect the position far away from the calcium. And after this step, we change to the workhorse wire, I change to the SION wire, and then 3 directing stent implantations, and this is the final results. For my conclusions, for operators who are to become the expert, it is very important to understand your characteristic of your guide wire, benefit different between the guide wire for the procedural success. And you select the guide wire to give the operator the best chance for overcome the difficulty of the CTO PCI. Thank you for your attention.
Okay.
Okay.
Thank you very much, Dr. Thanawat. May I have a comment from Dr. Ane on how would you select the guide wire in this case if you were the operator?
Thank you very much, Dr. Marquez. Good afternoon, everyone. In this case, when we look back to the first presentation, it looked like that the region has a not totally occurred. It's just a subtotal occluded, and is a setting is a acute Cori syndrome, right? So I think that
Yes.
this region should not be very hard, but when you do the state PCI, maybe it finally totally occluded.
Yes.
So maybe the point is it's difficult to cross the region with the guide wire is maybe because of at the point of the nearly occluded at this point maybe have some calcium over there, and your wire is went to the subintimal space. So in my practice, usually I will start with a very soft wire like XTR together with microcatheter, and I will use orthogonal projection for check bilateral view and point the tip of the wire to the root of the vessel. Maybe we just only can cross with the only soft, very soft wire like the XTR. But if we cannot cross, and maybe we can escalate to Gaia second, Gaia first, Gaia series before step to the conquest series. Thank you.
Thank you.
Yeah.
And Dr.
Thank you.
Thanawat, I would like to ask you that I noticed that you use the guide extension in this case, right?
Yes.
So what happened to your guiding?
Actually, I chose the getting the extra backup. That is I thought that have the more support, but for when the Y, the first Y with the XT and Pilot 50 could not puncture the proximal cap, so I need to more support. It is easily to change the guide wire for the it's a cheaper the procedure if I success. So I use the Geisila to mother and child technique inside the extra backup guiding, and then I have the micro catheter and the guide wire. But after fail this step, so I changed the newer guide wire more safer. The design as to I think it is easier to make the more supported at that time. Yes.
I see. So Nakamatsu Sensei,
Yes.
do you have an opinion on the different selection of the filter XT or the XTR?
Okay.
in this
Thank you.
case?
Okay, thank you very much. The base nice presentation, very interesting case. And even if the just only the 3 months later, totally occluded, right? And there, okay. And first of all, maybe the tip injection in the in front of the CTO lesion, maybe they give us more good information, and maybe that we can see we have the chance to watch the microchannel by the tip injection. And there's another suggestion is please use double room microcatheter. And in front of the CTO entry, we can see the good branch, good side branch, and septal branch. And inside the septal branch and some of the simple guide wire. And after that, additionally, the double room microcatheter. And after that, we can get more good backup support. Okay, anyway, XT or XTR is which is better. And okay, and the handling maneuverability is very good. And that this XTR guide wire compared with XT. Since I usually use XTR guide wire. Thank you very much.
Thank you. Thank you for your comment, and thank you very much, Dr. Thanawat, for your nice presentation.
Thank you very
Thank you
much.
very much.
So we have some question from the attendee, but maybe I will ask after the next case presentation. So the next case presentation is from Dr. Anek Kanoksin. Dr. Anek Kanoksin is a very renowned interventionist in Thailand, and he is the hospital director of the Central Chest Institute of Thailand. Now, Dr. Anek Kanoksin will show us some case presentation about the usage of the CTO Guide Wire. So please go on.
Good afternoon, ladies and gentlemen. This is my great pleasure to present case sharing for ASAHI company, and I would like to thank Dr. Wenpet to organize this conference. Let me start with the slide. The case is a 48-year-old male with poor control diabetes and dyslipidemia. He presented in my hospital with heart failure and ischemic cardiomyopathy. LV function is about 28, and from the angiogram show from AP cranial show diffuse LAD stenosis with total occluded in the mid portion. And from the IO caudal view, this is a circumflex also totally occluded with a poor distal runoff of both LAD and circumflex. And RCA also have a totally occluded like this. So in this case, because of there are triple CTO with a poor distal runoff, so this case is not a candidate for CABG. When we look at the CTO from the angiogram, and this is a study from 3D micro CT image in the CTO segment, we demonstrate many neovascularization in the side of the CTO lesion. So it doesn't mean that totally occluded is just a fibrous tissue or calcium. It have some micro vascular insights. And when we studied from the CTO histopathology, in the young CTO, it has a lot of microchannels inside the CTO body. So this is the chain of, we can use slippery wire like the hydrophilic wire to cross this microchannel. But when the CTO got older and older, the microchannel is disappear and replaced with collagen. So this is maybe have some stiffness, and this is has a difference between younger CTO and older CTO. So when we found that the CTO, younger CTO have some microchannel like this is called microchannel positive. This is when we approach in this CTO lesion, we should start with the hydrophilic cord taper tip wire like the filter XT or XTR. But when the CTO become older and loss of microchannel like this is a microchannel negative and have just only fiber tissue. This is a central soft core part. So we can use a puncture like a more stiffer wire. And CTO is become longer and replaced with the calcium. in this lesion, sometimes we need a harder or stiffer wire to cross the lesion because of the microchannel is not presented, and the central soft core plaque is replaced with calcium, so this is a hard plaque. So my strategy to start, I start first with the exploring strategy to find microchannel first, and escalation to the more stiffer wire and more stiffer. Because of if we started with stiffer wire like ASAHI or Conquest, maybe we can destroy the microchannel and cause into subintimal space. And when we look at the microchannel itself, the neovascular channel is size is about 100 to 300 micron. And for the conventional 014 guide wire is about 360 micron compared to the 0.009 inch wire is about 230 micron. So this is why we should start with a taper tip guide wire to explore the microchannel. So in this case, I started with, this is many years ago. So at that time, we don't have a Finder XTR. So I started Finder XT first with microcatheter and use exploring strategy with microchannel tracking, and we can successfully cross with only XTY and finish with stent like this. And after this, I scheduled to do state PCI to the CTO LED. Again, we start with the exploring strategy first with Finder X3 and microcatheter for microchannel tracking. And this lesion was successfully crossed with only one CTOY and finished with stenting. And at this time, we follow up the LV ejection fraction was improved from 28 to 48%. And last time we stayed PCI to zero circumflex. And again, use just only XT guide wire to track microchannel, and finally successfully with one standing here like this. And this at this time, after follow-up, the aviation was improved to normal function like this. And patient out of heart failure and functional class become a class 1. So let me look back to the guide wire escalation strategy. From the old strategy, recommendation from the first time, they recommend to start with intermediate guide wire and escalate to ultimate boss or miracle series and use a dealing technique and escalate to the conquest family after that. But this strategy increased risk of suboptimal passage. So sometimes this can cause intramural hematoma and cause of complication of dissection. In my strategy, I use maybe different from other because I from Kurashiki Central Hospital, so I start with use of Dr. Misuro concept. This is called feeder touch techniques, like the feeder to touch the lesion. So recommendation first is just use XTR for microchannel tracking. And then if we cannot explore, if we cannot find the microchannel, we can escalate to the Gaia series using active wire control. And then it cannot cross, maybe we can step up to the conquest family. The concept of Antegrade approach, the first strategy should start with microchannel tracking, so that this the reason that why I start with XTR first for tracking the microchannel and escalate to penetration strategy. And sometimes, but not frequently, use a during strategy because during strategy is quite dangerous to pass to subintimal space. And the mechanism of wire control, in the previous, when we use, we don't realize about this concept, so we use a passive control. But nowadays we try to use only active wire control to do the torque control, deflection control. And nowadays the newer technique is just use a new approach, is a 3D wiring. And the case number 2 is a tri-male, 44 years old, come with poor LV function. EF is about 39. And from the angiogram show left main plus triple vessel disease and CTO at the proximal LID like this. So in this case, we try to do the PCI to CTO LID. And at the time, she started with intermediate Y, but intermediate Y went wrong direction and went into subintimal space when we check with the other view. So in this case, I changed my strategy with use Conquest Pro with 5 chord to using a penetrating strategy. And when the tip of the Conquest attack do the CTO entry, I use simultaneous biplane fluoroscopy and just use deflection and direction control and puncture to the calcium. And finally, the wire went into the two lumen like this. And the next is active wire control that I mentioned earlier is 3D wiring for CTO PCI. In this situation, maybe we need the biplane using a multi-directional, and both plane is orthogonal view. And when we run the image, should do it perpendicular to the vessel axis, and sometimes need simultaneous biplane fluoroscopy. And the projection angle is about for perpendicular vessel. For example, is RCA, which should from the RCA we can do the orthogonal view like the IAO 30 and LAO 60, and run it perpendicular to the vessel axis like this. The green circle. The advantage of orthogonal projection, because of if we use orthogonal view by plane, it can reduce by area of the guide wire shaft and also the guide wire tip to reduce the wire area to pass through the two lumen. So requirement for 3D antegrade wiring, you need a biplane. Prefer to use a biplane more than single plane fluoroscopy. And the guide wire for manipulation, we need one-to-one torque guide wire like the Conquest or Gaia family. And the last one is we need a distal target marker like a calcium or contact or metallic clip or parallel wire or distal retrograde guide wire tip. The case number 3 is a 78-year-old male CTO RCA like this. When I successfully crossed the proximal lesion to the guide wire tip attached to the CTO axis point, but it went to subintimal space. So I started to use orthogonal projection. This is IO 30 and IO 60. And when we look at the angiogram from the LAO 60, the guide wire in the middle portion of the guide wire shaft is in the middle portion of the vessels. But at the IO 30, the guide wire shaft is on the left side of the vessel lumen. When we have this both view, we can create the cross-sectional view to create a 3 dimension. So started with the guide wire shaft in the middle portion from the LAO 60. So the shaft can be located in three locations like this. But when we look at the IO 30, the guide wire shaft on the left side of the screen is mean that when we look at this view, the guide wire shaft should be located here. And the next step, the second step is where is the guide wire tip? The guide wire tip point to the vessel lumen like this. And from the IO30, the guide wire is point to on the left side of the lumen and point to the lumen. So it means that the guide wire tip is point to here.
Hello?
So I need to turn the guide wire about 45 degrees to point to the top. So in this case, I finally managed to successfully cross CTO region axis with 3D wiring. And finishing, this is a contrast media injection from the contralateral view, contralateral injection. And finally, I successful PCI with a 3 stent.
ขอโทษทีผมไม่อยู่ในคอนเฟอเรนซ์
Finally, the conclusion when we
ผมอยู่
started
ในซูมคอนเฟอเรนซ์อยู่ที่รามจะมีอะไรฮะ
when we started with guide wire
เดี๋ยวผมต้องพูดอาจารย์
I started to try to cross the region with intimal tracking, but sometimes it cannot cross the with intimal tracking. Maybe we can use subintimal tracking and re-entry. But if we cannot successfully cross with antegrade, maybe we can use a retrograde approach. But this is the style mean that the strategy that we should use to cross intimal tracking as much as possible. But if I not successfully cross with intimal tracking, maybe I can accept the subintimal tracking. But I don't like to use knuckle wire. So if the situation that we need the knuckle wire, I will ask Dr. Nakamasu to help me. Thank you very much.
Thank you very much, Dr. Annie, for your great presentation. I have a quick question here about the 3D wiring. Do you think it's necessary to do the 3D wiring in the CTO body, or it's just necessary to do this near the distal exit point to the distal true lumen?
Very, thank you. It's a very interesting question. Because of CTO, sometimes we cannot create the root of the CTO body because of their maybe diffuse disease. So not always we can use 3D wiring in the CTO body because of maybe because we cannot make the perpendicular view along the vessel wall axis, and maybe we don't really know where is the CTO body. Sometimes even we use the perpendicular to the vessel, but if we cannot create the CTO body root, it still need to use your hand tactile feeling. But for the CTO axis point, sometimes when we clearly see the point of axis, it need very pinpoint to puncture to cross to the true lumen. So it quite very helpful for us to use 3D wiring to cross the T2 axis.
Thank you very much. And you just mentioned about the knuckle wire, and we have a question from the attendee about the knuckle wire. So the question is, when we use the full polymer jacket Sion black for the knuckle wire technique, how to make sure that the wire is in the true lumen and not causing a vessel perforation? Maybe I would like to ask Dr. Nakamatsu and Dr. Ane for this question.
Dr. Nakamatsu may be more expert than me because I never been used knuckle wire before. Because I know that if you use knuckle wire, it means that you cross the subintimal space. Right.
Okay, so please, Dr. Nakamatsu.
Yes, and I completely agree. So knuckle wire technique is like a final option. Yeah, and basically that we have to track in the intima. Okay, anyway. So there, and once the perforated using the knuckle wire, and this complication is quite big, and so I usually push in a very soft pushing power, and there if they perform their little PCI, and how to say that, and insertion Antegrade guide wire and a little guide wire, big and both sides and like a kissing, and after that pushing the both guide wire with knuckle shape, and because and insertion the another guide wire. So this guide wire is a good mark and for the base position. Okay. So the so we have to keep the pushing power with soft, very kindly pushing. This is the key point.
So, and please correct me if I'm wrong. I heard that we can use the polymer jacket like a Sion black or the pilot wire or the like a. I heard about the Gladius wire. This is the good wire for do the knuckle technique.
Mm-hmm. Okay, thank you very much. And so anyway, so there are each guide wire and can make a knuckle shape automatically. Which how about the difference and from those guide wire is a pushing power, and more hard tip rod is we can push the more heavier tip rod, but but automatically and simultaneously the increase in the perforation risk. Usually my recommendation, please start from the Sion black. Thank you.
I see. Thank you very much.
You're welcome.
And, maybe we will ask the question from the attendee now before we go to the next session about the guiding catheter. So the next question is Sion black same as filter SC? Is Sion black same as filter SC? So maybe you can give us some information about it.
Okay. May I talk this? Okay. And completely different. And former type filter FC don't have composite core. And but on the other hand, the Sion black have the composite core. And the problem of the maneuverability of the polymer jacket is due to the polymer jacket and how to say the torque transmission, the power and torque transmission efficacy is poor and compared with the coil guide wire, but a little bit more improved, and they're using the composite core, and especially the Sion black guide wire have the composite core, and due to that this composite core a little bit improved, not big very improved, and the over the maneuverability compared with the filter FC.
Thank you. And next, in which scenario we can base straight use guide third without escalating from the first and second for the cost saving of the first? That's the question. Dr. Viraj, could you comment on this?
Open the please, Dr. Viraj.
I cannot hear your voice.
Okay, unmute now. I think the guide third is not my first guide wire at all, because the problem is that once you use the guide third, you should think of the very hard situation, such as the you need some more penetration force and more control. But since the lesion you deal with, you cannot expect that how long or how old of this lesion. So the better you should try with the softer one. I think for the cost concern is not the real reason to use the very strong full guide wire for the first option, since you can cause injury, and sometimes I think the guide wire that you feel familiar is the best guide wire for the first guide wire choose. This is my opinion.
Thank you very much. And Dr. Anek, do you have any situation that you will choose the Gaia third as the start wire?
Actually, I rarely use Gaia third because of after we cannot cross with field XTR, I escalate to Gaia first. And most of the case we can cross with the Gaia first. But maybe sometimes we need a more stiffer. I just escalate to the Gaia second. If Gaia second not successfully cross, I step up to the conquest. Not use. I rarely use Gaia third because of when you start with a very stiff wire and not do the escalation wire, you can lose. You can lose the case that they might have some micro-channel that the soft wire can cross, and not quite sure that all the wire in the two lumen in the not in the subintimal space. So when you use the more stiffer wire at the first wire, and it's quite easy to create the guide wire into the subintimal space. So you cannot go back to use the soft wire again.
I see. Thank you. Dr. Dakapasu, in any situation that you prefer Conquest Pro guide wire over the Gaia series?
Okay. And this Conquest Pro have their very tough wash out, and how to say that flexibility is there. Don't have as a Conquest Pro don't have the flexibility compared with the Gaia family, as you know. And just only I use the Conquest is a puncture, straighten puncture. And like just only the CTO entry hard cap or the very hard distal cap. So in this time, if the pushing the guide wire at the CTO exit, yes, and mandatorily the CTO and seeing the CTO exit, just a puncture.
I quite agree. Sometimes we do the escalated wire and de-escalated. After puncture the calcium and de-escalated to the softer wire.
I agree. Thank you.
I have a question for all panelists. We choose to realize the concept of the invisible microchannel. Ajahn Anek, Ajahn Virat are my teacher, and they taught me after graduate. I realized this concept too much. So every case I start with the filter XT series, every case. But after many years of practice, I have the higher rate to step up to the stiffer wire. And you know, my hospital is not rich hospital, and my boss say you use too much medical wire. So if for case that we don't see any micro channel, we choose to use the first wire as the stiffer wire. What is your recommendations for our panelists? Yes.
I still recommend you to start with a softer wire because if you only use softer wire and successfully cross, you're quite very sure that this is in the two lumen, not clear the dissection. But as we know, it depends on the time of CTO. The younger CTO maybe have a lot of microchannel, but we don't really know that which one is younger or older or still have microchannel or not. And sometimes we cannot see from the angiogram only.
I'm very agree to Dr. Annie. I think just one soft wire to check if there are any loose tissue for tracking is reasonable. I think if I agree with Dr. Annie that we should not lose the chance to do the loose tissue tracking. And I think if just the XTR or XT could not pass, so we can step up. I think it's reasonable to do this. How about Dr. Viraj and Dr. Nakamatsu?
At first, I have to clarify that you understood is not really right because microchannel is some terminology for the histology, and it's not be able to see in the X-ray machine because the channel is quite small, about 100 to 300 micron. Almost always there's no any machine, X-ray machine that can see this small channel. So this is you have to touch it to feel if it's a loose tissue or not. So first start with the soft tip tapering guide wire. I think is the best choice. And once if you have a very good tactile feel or tactile sense, you will know that the next guide wire you will choose what kind of guide wire you will be.
Thank you very much.
So Dr. Nakamatsu.
Thank you very much. So I know well the practical problems. I know, and the medical resources that this is actually a very big problem. Anyway, and basically the CTO PCI we need some guide wires. Basically, this is a CTO PCI procedure, and I have the one recommendation. And please do the tip injection, and every time. And if we can see the very tiny channel or just only the haziness, that if we can see the haziness, we have the chance and using a loose tissue tracking. Thank you.
Okay. Thank you very much.
Thank you very much.
So we are behind the schedule now, so I would like to move to the next section. It's the lecture about the selection of the guiding catheter by Dr. Viraj from Central Chest Institute of Thailand. So Dr. Viraj, please start your lecture.
Okay. First, thank you for invitation, and I quite appreciate to give this lecture. I think I was informed to be this is a lecture for the beginner, so I will try to summarize the concept of the guide catheter uses in the PCI. This is my disclosure. The first, this is a term that quite well described about the guiding catheter uses. Dr. Bernhard Meyer has write in the in Journal Invasive Cardiology in 2005. He mentioned that the guiding catheter is the most underrated asset to coronary angioplasty. That means that most of the intervention did not pay attention or give the importance to this this basic device. Because a good choice of the guiding catheter makes the subsequent procedure become more simple and without the need to resort to complicated hardware that expose the patient to unnecessary risk and cost. The function of the guiding catheter is first is a conduit for the device and wire transport. And second, you have to use the very good support catheter to support the device advancement. And the other function is the vesicle for the contrast or medication injection. And the last one is the measurement of the pressure during the operation. This diagram, I think, is explain well how important the guiding catheter is. Look like you try to build up a great pyramid. The base of the pyramid should be very strong and wide, and should support the top up of the other step, like the guide wire, the microcatheter, or many special devices. So if you do not build the pyramid with a strong base enough, then you cannot build to the top of the pyramid. And the part of the catheter, there will be a terminology that we should familiar with. The catheter composed of the shaft of the catheter. At the tip, they have a special curve in the different type of the catheter, but most will compose of the secondary curve and the primary curve. And we have to make a radio opaque marker at the tip to identify the catheter better during the operation. And the tip, another end of the catheter will be a hub that we use to for connect to the pressure connector and other device. Usual length of the catheter is 100 centimeter, and some catheter maybe have a special tertiary curve to make better support. Compared to the catheter part, the tip of the catheter always the softest one, and we can call this is a safety zone. And the primary curve and the secondary curve become the flex zone, that the stiffness will become higher, and the sharp will be the most stiffness form. The important characteristic of the guiding catheter, you should have a traumatic tip for the safety of the operation. You have the proper perform check that should make a coaxial with the vessel to enhance the support and advancement of the device. And you should have a very good torque control to control the catheter top with the active support. And when you have to torque the catheter should be strong enough to be kink resistant. And you should see the catheter well during your operation to avoid the trauma by the catheter. And the last one is a durability of the catheter, because sometimes your procedure may take a longer time in the complex situation. So the durability of the catheter or the anti-heat deformation may be necessary. The selection of the catheter based on many factors. The first one is the construction material. The catheter consists of the multiple layer of the polyethylene or the polyurethane that make it flexible. But inside there will be inside this plastic, there will be a steel braid that make it stronger enough. And after that, we need a coating to reduce the friction during the passage of the guiding catheter. The braid layer inside the catheter will provide strength to maintain the luminal shape and the kink resistance as well, and help force transmit both the torque and push. The other factor is the dimension of the catheter, include the diameter and the length. The diameter you need for the lumen requirement, both the passage of the catheter inside the body and passage of the device inside the catheter itself. So this related to the access arterial side. Almost always in the modern practice, we use 6 to 7 French per catheter. But in the complex situation, such as the left main stenosis, I will still prefer the 7 French. The length of the catheter now, most of the catheter come with the standard length 100 centimeter. You may find the shorter one for the some situations such as the tortuous lemma or the graph intervention, as well as the retrograde approach to allow the extension of the device outside the guiding longer than usual. For the one who have a tortuous aorta or unusual tall patient, sometimes you need a very long guiding catheter, but I have to say that I never see a catheter more than longer than 100 centimeter, but you can be fine in some country. The other factor is the lumen. We have described two parameters, the outer diameter and the inner diameter. The outer diameter we measure in French size, and this is a standard 5 French, 6 French, 7 French, and 8 French. 1 French is equal to 1/3 of the millimeter. The inner diameter may vary from the construction of the catheter. If you can make the wall become thinner, you can get a bigger inner diameter. In the market, there will be the next the new generation. You will have a bigger inner diameter compared to in the same French size compared to the old version. This is a benefit to select a smaller catheter size, French size, and you can approach from the radial or the use the smaller system to less the complication as well. For the example, 5 French is better for the balloon angioplasty alone without any other complicated device. Or the 6 French is a standard angioplasty with stenting, and you can use the angiojet catheter inside this. But for a wider lumen, you can do some bifurcation, include the IOS catheter. And for 7 French, I think this is good for the use of the complex device such as a big burr rotator or the 2 rapid exchange balloon catheter, even the 2 simultaneous stenting. But for the very big rotaburr or the complex device such as the direct coronary atherectomy, you need a very big catheter such as the 8 to 9 French. The advantage for the small catheter is that you have a smaller puncture, you have a smaller vessel access and less trauma, and even the less breathing complication, and allow the deeper engagement in case that you need the active support. But the larger one, they have the advantage in the increased torque and support and improve the visualization and allow many devices to go in the same time. The disadvantage for the small one is that the less torque, reduced visualization, and less support. As well as the bigger catheter, you have to use a larger puncture and more complication and more blood loss. Another factor is the distal curve. This is determined its function. Actually, the curve of the guiding catheter, they start with the curve with 2 curves, only the primary curve or secondary curve. But nowadays, some catheters such as the Hyperion, they will be with the 3rd curve to improve the support. In the market, you can find many shapes of catheter available. So the selection of the catheter is depend on the operator and how familiar you use. A guiding selection may based on the anatomy of the aorta root as well. A smaller or the aortic root, you can use a standard guiding catheter. But for a wide aortic root, you may need a very big curved catheter. If the curve you choose is too small, the catheter will become backward flow. But if the curve is too long, you cannot access the ostium of the target vessel. And the component for the excellent guiding catheter is a tip orientation. You need a good engagement of the catheter tip. You need a coaxial alignment of the catheter tip with the artery to make the device easily pass. and you need backup support that especially if support point directly opposite to the ostium, and you need a large area of support for the contralateral wall to enhance the support as well. The passive support make you rarely have to deep seat the catheter, since the catheter curve itself can support any device and any procedure you did, and then you can have hardly to manipulate the catheter as well. For passive support will be enhanced by the shape of the catheter, especially for the this opposite wall size. But if the curve of the catheter cannot give your support well, you can make the active support. This is you have to manipulate to use the electric root to form a desired curve shape and provide backup support, and rely on the active manipulation of the guiding catheter to obtain a stable position as well. And maybe you have to deep seat and coaxially to the and selectively into the artery, such as in case of the left main, you may have to select it into the LAD or circumflex instead. This is an example of the active support. In this case, you can see that the catheter, the right jacking, cannot sit into the right chordae well. So in this case, we manipulate the catheter until it's become more active support, more touch to the opposite wall, and you can inject the catheter at the contrast more vigorous, and in the last you can support the device to PCI this artery. The last feature is maybe the combine of the coating with the radial opaque tip and the side hole, etc. One point that I would like to mention is that the radial opaque marker, not every catheter in the market have the radial opaque marker at the same place. Such as some catheter may have a radial opaque marker a bit away from the tip, but some will be exactly at the tip. So before you use this guiding catheter, you should know well that where is the radial opaque marker. The side hole is something that very important, especially you use a bigger catheter for a smaller artery, since the side hole can prevent the catheter pressure damping and allow the additional blood flow out of the tip to fulfill the artery during the procedure. And maybe it can avoid a dissection at the ostium of the artery if you handle carefully. But the disadvantage is that you have the false sense of the security, because the electric pressure now is always good in and you may lose a lot of the contrast media during the injection, and maybe it can reduce the backup support. This is a case that they use the side hole catheter perform the PCI, and the pressure is very well all the time they perform. But when they inject the contrast media, the contrast media have caused a aortic dissection. The access side of the PCI nowadays we prefer the radial. The radial have some important point that the right radial approach always have the 2 points of resistance during the passage of the catheter. But if you use the left radial approach, there will always the 1 point of resistance, like in the case of the femoral approach. So in the transfemoral approach, if you prefer the robust sharp catheter, the left transradial will be similar to the transfemoral. But for the right transradial, you should choose a more flexible sharp catheter to avoid the injury, and maybe you need active support to manipulate the catheter more than the transfemoral or the left side approach. This is a picture show the physics of the guiding catheter for the left Corey. When you approach from the right radial, you can see that there are many factors. Actually, I don't like physics, but I can simplify it that the angle for the catheter wall and the catheter tip is quite important factor to make you get the maximal backup force. And the other factor is this lambda, that is the static friction, as well as the contact area catheter at the opposite side to enhance the catheter support. So in this case, you can see that transradial compared to the transfemoral with the same curve, you can get very high support from the transfemoral in the same curve compared to the transradial. And if you use extra support catheter from the right radial, this is an ecalic curve. It will give you the higher support that comparable to the transfemoral. And once you compare the different curve from the transradial, the four-fan catheter, the JL4 in this case, they will have a stiffer angle. So the support is not as good as in the JL 3.5. But once you deep engage this JL4 inside and make this angle become bigger, the guiding support will become higher. And in this picture, they put a composite picture, combine the approach of the same catheter from the right radial artery and the left radial artery, and mix merge into the same picture. And this is a computerized tomogram to show you that from the left and right, you will have a different catheter attached to the wall, and the direction that point to the target artery will be not the same. In this tomography, you can see that from the right artery, the shaft always attached to the anterior wall of the aorta, while from the left side, the shaft will attach to the posterior wall as well. So except for the angle and the physics of the catheter, the shape of the catheter from the different route may be not the same. In some cases, you can use the universal radial guide catheter. This catheter can be performed both the right and left approach, right and left coronary artery approach, such as the Kimi catheter, the MAC catheter, and the ecalic catheter. But the universal catheter has some disadvantages as well, because almost always there will be a higher cost, and you need a learning curve, and also potential more catheter manipulation, quite difficult for the beginner. But it's good for a single pass through the radial artery that is less potential to cause a spasm. The radial approach may have some disadvantage that if you choose some catheter that have a steep tip, they will cause some laser effect and can cause the injury to the artery as well. In such a case, you need some technique called the balloon axis tracking technique. Use smaller balloon with the PCI wire to inflate at the tip of the catheter. This will abolish the sharpness of the catheter tip, so you can send this catheter across the tortuous part of the artery safer. And the other factor, you can choose some guiding catheter which provide a round tip, maybe safer to not to cause the injury of the artery, such as in the Hyperion catheter, which have a round tip. For the radial artery access, you have another choice for the bigger catheter. From the RC, we have the sheaths catheter. But if you feel that the sheaths is not convenient because the conventional one is the over-the-wire system. But this over-the-wire system only come with the 120 centimeter, so the extension part is quite short, and you have to prepare with a very sophisticated way. Compared to the newer version is such as the guide liner or the guide silla is a monorail type. They provide a longer the catheter extension and also convenient to use. And this is some situation you need the guiding extension catheter, such as in this case, you have choose already extra support the guiding catheter, but still the catheter is still far away from the ostium. So we can extend the catheter using this guiding extension catheter. Or in such a case that you need to enhance the support for the balloon catheter or the stent catheter in the distal part of the artery, this is very useful. In case that you need a short guiding catheter for little grade CTO procedure or for the Lima approach, you can make it yourself in the cath lab using the cutting the technique and combine, reconnect it up with the sheet. You can find this in some literature. I will end up with the basic guiding catheter skill. To handle the catheter, I find that we use the same maneuver with the guide wire manipulation. You should use your right hand to control the torque, and you should use your left hand to control the to and fro action of the catheter. This will help to transmit the torque to the tip, and you can fine tune to control the catheter tip as well. And avoid excessive torque catheter, since I think this situation may often see in the early years of the training. But in some case, in some tortuous artery that you did not concern, the expert also can do wrong. And the most of the technique, sometimes you cannot find a very strong catheter in some difficult situation. I still prefer to use assist wire, use a standard O35 wire to left inside the catheter while talking. This will prevent the catheter kink and also provide a better torque control. And how to inject the contrast during you have a O35 wire inside, you have to connect like this in the tree bot to provide the catheter support in the with a guide wire with able to use a contrast injection during the procedure. In this case, you have a AR catheter that you need to engage the right one, and it's quite difficult to torque. So I put an O35 wire to enhance the tip of the catheter end to torque the catheter safely. And in another case, we use a O35 wire to support, and you can use inject during the manipulation catheter to find out where is the ostium. And many situations with the anomalous origin, you may need PCI wire to advance before catheter seating. This is have like to a telescopic technique to enhance the tip of the catheter control to forward the ostium of the artery. And in the case that you cannot manipulate the PCI wire, you may use a standard guide wire to support combined with this PCI wire. In this case, I put the standard guide wire to make the curve of the catheter become more straightful, and then send a PCI wire inside this anomalous artery. And the second guide wire and second balloon as an anchoring technique may be useful in to help stabilize the guiding catheter as well. In some difficult situation, you should think out the abnormality of the aortic root, abnormality or the congenital abnormality of the aortic arch. or origin of the category osteo, and maybe some aortic plaque or obstruction at the osteo. So in case that you cannot find the osteo with the guiding catheter, try to manipulate the catheter carefully and always use a contrast to inject to confirm where is it. And maybe sometime in case that you deal with the aortic valve disease, they will get from the aortic valve that push on the guiding catheter and make you control the catheter more difficult. And the last one is the calcified aortic lesion, also very make you become difficult to handle with the guiding catheter. In all of this situation, you should be careful on manipulate the guiding catheter during the operation. So this my summary on the guiding catheter. Hope that you can help all of you to start your PCI with the more strong backup. Thank you very much.
Thank you very much for your informative lecture. So, and I have a question from the attendee for you. The question is, if we plan for kissing balloon technique in bifurcation lesion, when we choose 7 French over 6 French guiding catheter in regard to the balloon size that we will use? That's the question.
Sorry, I cannot hear the end of the question.
If you plan to do the kissing balloon technique,
yes,
the bifurcation PCI, when should we use 7 French over 6 French guiding catheter in regard to the size of the balloon?
I think the size of the catheter, the 7 French, allow you to put more device inside. In some situations, you may have to put more than 2 guide wire in some left main bifurcation. Or in some situation, you cannot send the balloon well. You may need somebody wire or etc. So a 7 French may be a better choice for this situation. In 6 French, you can send the modern balloon, 2 balloons together, quite convenient. But once the balloon become used, I mean, if you inflate the balloon once, the balloon have some not well rewraps, then they will become a bulky, and almost always you will feel that there is some resistance while you try to put this 2 balloons together to perform a kissing. And the other reason is that sometimes the crossing the strut of the stent in the left main bifurcation, you need also a very strong support. A 7 French always do well with compared to the 6 French.
Thank you. I think they wants to know about the size of the balloon that expected to use. I mean, like 2 3.5 balloons or 1/4 3.5 balloon. Is it compatible to like a 6 French guide catheter or not, or you need a 7 French? I myself could not remember.
Actually, the balloon, the most bulky part of the balloon during the transport through the guiding catheter is the shaft of the balloon, and the tip of the balloon, if the balloon is well wrapped, it's always not bigger than the shaft. So in the modern balloon, the shaft of the balloon have construct very well, especially at the exit part of the monorail catheter, so that the catheter, the monorail guide wire exit maybe make the wire quite like very thin, and like to when combined to the catheter shaft and wire, then diameter is not much bigger. So no matter how big of the balloon in the modern balloon, you can put two balloons together in a sequence. But the problem is that after balloon inflation, maybe the bulky deflated balloon prevent you to pull back the balloon together. So you can you have to remove one by one.
Thank you very much. So, so for the sake of time, I would like to move to the next session, so we can have time to answer the rest of the question from the attendee. So, the next presentation will be Dr. Viraj. Please stop sharing the screen, please. Thank you very much. So the next presenter is me. I will present sorry. Oh. So please let me share my screen. The next presenter is me. Okay. Okay, I will show you the case about the selection of the guiding catheter and how to improve the guide stability. So this is a case of 89-year-old male with hypertension, dyslipidemia, gout, and BPH. So he presented 8 months ago in another hospital with non-STEMI with congestive heart failure. The echocardiogram show LVEF of 45% with mid to apical inferior wall hypokinesia. The angiogram performed at the previous hospital show severe stenosis in the proximal part of LAD with calcification, and also the proximal part of the LCX have severe disease. And you can see that there are septal collateral to RCA and apical collateral channel to the RCA as well. And the RCA have proximal to mid total occlusion with the severe calcification. You can see from the angiogram. So in conclusion, this is the a left main with a triple vessel disease with CTO proximal RCA with severe calcification, and severe calcification in proximal LAD and proximal LCX with syntax score 56. But the patient deny CABG, so they refer this patient to my hospital for PCI. I performed the MRI to assess the viability of RCA, and it showed that there is ischemic scar involving RCA and LCX territory, but they are most likely viable. LVEF was 32%. And my strategic plan is to perform the PCI to the CTO proximal RCA first. And this CTO have a JC2 score of 2 by severe calcification and lesion length. And I plan to do the bilateral simultaneous injection from to left coronary artery by the right radial axis using 5 French diagnostic catheter, and from right femoral axis using a long sheet catheter with 7 French AL1 side hole guiding catheter from to right coronary artery, because I noticed from the previous angiogram that his descending aorta is quite tortuous. And I plan to start with the antegrade wiring technique, and if fail, I do the wire escalation, and if fail, I will do the retrograde technique via the apical channel. And we have to plan for the calcification management because we see the severe calcification by the angiogram. So, at the time of the PCI, you can see that there is a very severe tortuosity of the aorta. And also the right brachiocephalic artery is very severe tortuous, as you can see. So, and I used the 45 centimeter long sheet from the femoral access. And I choose 7 French AL1 guiding catheter with side hole for the RCA. And you can see that from the bilateral injection, the CTO is quite long, and there is apical collateral channel from the septal near the apex. And I start with the XTA and Septal, which I can pass the wire through the CTO lesion to distal through lumen. But the device could not pass Septal microcatheter, and the 1.0 millimeter sapphire to a balloon could not pass the lesion. And you can see that the catheter was backing out all the time that I advanced the balloon. So what to do next? Switch to the lower profile microcatheter like Caravelle, or use one or more body wire, or use the side branch anchoring technique to increase the guide support, or do the rotational atherectomy, or do the subintimal crossing, and then inflate in the subintima to modify the CTO. So I start with the anchoring balloon technique in the conus branch to increase the support of the catheter. I try to pass the 1.0 millimeter sapphire balloon and Septal, but they still could not pass the lesion. So I tried the conus catheter, but could not pass as well. So next, I have no choice. So I pass the Septal microcatheter as far as possible, and then I remove the PCI guide wire, and I do the direct wiring with the rota wire floppy across the CTO segment. But I think when I look back, I think it will be better if I use the rota wire support type, because it will be more easier to manipulate and give more support. Because when I did the rotabulation with the 1.25 millimeter burr, it could not pass, and you can see that the rota floppy wire is not stable, and doesn't provide enough support. So I did many sessions of rotabulation, but the rota burr could not pass, and the wire and the guiding catheter was backing out of the time. I start with the rotational speed of 180,000, and then I increase to 200,000, but still could not pass. So I try to advance the rota wire during the dynaglide mode as far as possible. After that, this time the rotor can pass the lesion. So I use the high-speed technique with 190,000 RPM, and then I switch to the low speed. And after that, I did the pre-dilatation with 2O balloon and 2.5 millimeter NC balloon. And because I use the side hole guiding catheter, and I want to do the OCT to assess that if the calcium is cracked or not. So you know that if we use the side hole guiding catheter, the contrast media will go out into the aorta via the side hole. So in this case, I use the guide extension to seal the guide hole in the guiding catheter. And because I do this because I plan to use this for the stent delivery as well. So you can see that we can do the OCT with the side hole guiding catheter by this technique. So for the sake of time, I will skip this and summarize like this. So after the rotation and ballooning, you can see multiple cracks of the calcium, and this is the effect of the rotation. And you can see multiple crack of the calcium here. So now we can put the stent, and I put 2.25 millimeter stent from RPD to distal RCA and 3O stent in the distal RCA, and then I put long stent in the mid RCA. So I have to use the guide extension to increase the support for the stent delivery, and also for the proximal stent, and I stent up to the ostium, and you can see from this OCT that the stent is well expanded, and we get a good result. And this is the final angiography. So I want to summary my perspective from this case. So the basic function of the guiding catheter provide a conduit for the delivery of the equipment with simultaneous contrast injection and pressure monitoring. So this is depending on the size of the guiding catheter and the side hole versus no side hole of the catheter. And the second function is to provide the support for the device passage to the target site. And the factor to determine is the size and the physical characteristic of the guiding catheter and the ostium of the corollary and the aorta. So about the physical characteristic of the guiding catheter, about backup support. What is the backup support? The backup support is the ability of the guiding catheter to remain in the stable and fixed position while the PCI hardware is advancing forward over a guide wire without backing off. So, and the passive backup catheter is relying on the property of the shaft and the tip of the catheter, but the active backup catheter is rely on the active manipulation of the guiding. And one point to know, if you use the passive backup catheter, you can get additional active support in almost all case, but not all case. Like in case that you use the big size guiding catheter like a 7 French or 8 French, I think it's not safe to to do the deep seat of the guiding catheter like this case. But if you use the active backup catheter, you never be able to get additional passive support. Sorry, it's my mistake. You cannot get additional passive support with only few exception. So the reason that I choose the 7 French AL1 with side hole guiding catheter and long sheet in this case, because I want the passive backup, because this is the CTO RCA with the severe calcification, and it is not necessary to continually manipulate the guiding catheter during the procedure. So it's allowing us to concentrate on manipulating other device. And because in this case, I expect the need for the rotational atherectomy. And in this particular balloon uncrossable case, so I did the lesion modifying by the lower profile balloon and the tonus, but seem not effective. So I enhanced the guide support by the anchor balloon technique and the guide extension. And anyway, I have to do the rotational atherectomy for lesion modifying. And the use of the side hole or the non-side hole guiding catheter, I think is the issue for the discussion. The advantage is we may decrease the risk of hydraulic dissection during contrast injection and allow some antegrade flow, but some doctors say it may provide a false sense of security because we are monitoring aortic pressure instead of the coronary pressure. And the problem is there will be the escape of the contrast media into the aorta through the side hole, and we cannot perform the OCT with the side hole, but this can be managed by occluding the side hole by the guide extension like this case. So thank you for your attention. So I would like to ask Dr. Thanawat, do you use the side hole guiding catheter in your daily practice?
No, actually, I use the side hole guiding catheter in the very severe oscillation because I have the more controllable the pressure and controllable the devices in these situations. But otherwise, I use just the normal guiding, no side hole.
So I don't use it routinely as well, but I think for the CTO of the RCA is okay to use because we already have the collateral supply from the left coronary. So I think it's not so concerned about the ischemia, but I think we can avoid the hydraulic dissection. But for the left main intervention, I don't use. So I would like to ask Nakamatsu Sensei about this. I think many Japanese operator they like side hole guiding catheter.
Thank you very much. Good question. And usually I use a side hole guiding, and the aim is avoiding the coronary ischemia, and I would like to avoiding the contrast injury and using a big side guiding. And usually I use the side hole guiding catheter for using the 7 French and 8 French.
And for the left main, like a left CTO in the LAD or in the LCS, do you use the side hole for the left coronary system or not?
Okay. And especially the CTO case, I usually use, and even if the left coronary and the right coronary. And for the daily practice, and I usually, okay, and there is no severe lesion at outer part, so I don't use their side hole. This is my rule. And so I would like, in this times, I would like to mention about the pitfall of the side hole guiding. And one is very difficult to the monitoring and between the guiding tip to the side hole. So I have the one experience, and okay, and the pressure is monitoring is quite okay, but from the angiography we can see the thrombus at the tip of the guiding. And this is a pitfall one. And another pitfall is there, and when we perform the balloon trapping in the guiding, and sometimes the balloon perforation and occur due to the side hole. Thank you.
Interesting.
Very interesting. But I hear about ASAHI guiding the maker the side hole by the laser. And so I hear about the very difficult to the maker balloon rupture at the guiding using the ASAHI high pinion guiding. Thank you.
Okay. Thank you very much. I have one question. Do you consider put in a temporary pacemaker during a rotator of RCA? Or is it safe to do rotator without temporary pacemaker? So I will answer this question first. So in my practice, I will do like a short run first. So initially, I don't put the temporary pacemaker, but I will do the short run of the ablation. So if the patient develop bradycardia or heart block, then I will put in the temporary pacemaker. But if the heart block doesn't occur, so I think it is safe to proceed and just prepare the atropine. So maybe Dr. Viraj can comment on this because you are the ROTA expert.
Okay. I have not used the pacemaker routinely for many years. Since it's I think in the consensus of the expert in 2014 of the rotavator, they also did not recommend the routine use of this pacemaker, since most of the pacemaker is necessary only during the running of the rotavator, and most can be take off after you send the patient back to the ward. The other factor is that the pacemaker catheter itself also maybe can be cause a perforation of the right ventricle as well. So it's not always safe to put a temporary pacemaker inside the RV all the time. So in my practice, after I discontinue to use the pacemaker, I noticed that most of the case can tolerate the rota well, and I practice as you said that I start with the shorter run to evaluate how the patient responds. Atropine in my hand. In case that the patient have the slow heart rate, I give the atropine. In some expert, I saw in a Japanese expert, they give the pre-medication with the atropine before running the rotavator. That is also another practice. But I note that most of the patients with the very old age, the elderly, will have poor recover of this heart block compared to the younger one. So I think it may be safe for the case that you think that the high risk to have a prolonged heart block. You may prepare a venous sheath for the insertion of the pacemaker catheter, but do not have routinely put the pacemaker in the RV before the rotavator.
Okay, thank you very much. Next question for Dr. Ane. How about 3D wiring in LED CTO? Which view and angulation are the best visualized?
Actually, it depends on the hard the vessels. Normally, they recommend to use the LAO 45 and IO 45 is quite okay for the proximal and mid LAD CTO wiring for 3D wiring.
And about the LCX,
it's quite difficult for LCX to do the 3D wiring because of the angle is not normally is sometimes we just use biplane but not totally orthogonal view because of it's quite difficult for circumflex to make a 3D wiring because of by the nature of the circumflex is usually angulated and sometimes a bit tortuous. Even the CTO at the proximal circumflex is quite difficult to cross. So I think for 3D wiring is limited for the suitable case for the RCA and OAD.
I see. So for the distal RCA, you use a cranial and caudal view, right? Or the same?
For the distal is maybe we cannot use a 3D wiring. Just biplane and multiple directional view check, but it's suitable just only for the proximal and mid portion of the RCA.
Thank you very much. And Nakamatsu Sensei, you don't have the biplane in your hospital, so I noticed that you do the rotational angiography, right, to check the guide wire tip position, right?
Yes. Yes, anyway, so maybe that this rotation angiogram with that contrast issue is included that are making the image the perpendicular angles, I think.
Okay, so we still have one more question. So no, we have two questions. So what is the difference between Miracle and Gaia series? Oh, very difficult question. Could you give us a short answer? Like I'm saying.
Yes, it's quite different. The architecture is quite different, and the newer one is, as you know, the Gaia, and so more good flexibility and more good penetration efficacy. But on the other hand, the Miracle is have the sutil and have the efficacy, and because this Miracle guide wire have the tough core shaft. And so tough, and due to those tough core shaft, Miracle guide wire have the good, strong transmission power. You know, so maybe that you can and you have the experience about those Gaia wire very easy to the trap the calcification region, but the change to the Miracle guide wire like a Miracle 12, and after that we can do the rotation.
Okay, thank you very much.
Welcome.
So the last question will be for Dr. Anek. If microcatheter able to cross, what is the biggest balloon size that we can try next? Can you see the question?
For the CTO lesion, right?
I think yes.
It depends on the lesion which calcify or heavy calcify or angulation or not, or sometimes that it depends on the type of microcatheter. If you use like the Corsair, maybe you can use a bigger balloon, but for the small type of the small type of microcatheter, maybe you can use cannot use the bigger balloon. So in my idea, usually if we can use we can cross microcatheter, I think that we can try with 2.0 balloon or maybe 2.5 balloon.
Thank you very much.
For the simple lesion.
Okay. So I think we already answered all the questions from the attendee today, and we are running out of the schedule. So sorry for that. But so today I would like to thank you very much for all of the speakers to be here with us and providing a very informative lecture and case presentation. And I would like to thank all the attendees for joining, and also the ASAHI Intech company to organize this useful and informative virtual course. As you can see that almost all of the question is about the CTO wire. Actually, today we want to provide the basic of the guide wire for the non-CTO lesion for like the daily case, but you can see that all of the question is about the CTO. So probably we need to organize a more dedicated session for the CTO technique. But anyway, we will have the next course, the next series, focusing on the microcatheter and dual lumen catheter on September 19, and so the next guest speaker will be Dr. Yoshihisa Kinoshita from Toyohashi Heart Center, and we are expecting you to join us the next session. So, and today is a very useful moment to be with all of you. So thank you very much and have a nice evening. สวัสดีครับ